Unit 2 of the LPN IV therapy course covers homeostatic and regulatory functions. The objectives for this module include identifying the relationship between IV therapy and the body's homeostatic regulatory functions, emphasizing the anatomy and physiology of the cardiovascular and respiratory systems as related to homeostasis. Please see the syllabus for specific objectives. As we prepare to administer prescribed IV therapy, it is important to understand not only the underlying conditions that necessitate its use, but the potential effect of intravenous fluids, electrolytes, and vitamins on the patient. We will review body fluid composition, fluid distribution, fluid function, homeostatic mechanisms, and fluid volume imbalances in Part 1 of this lecture. In Part 2, we will discuss fundamentals of electrolyte balance and commonly used IV solutions. Let's talk about body fluid composition. Body fluid is body water in which electrolytes are dissolved. Body water constitutes approximately 50 to 60% of the total body weight. Body fat contains little water, and thus the percentage of total body water can vary based on the amount of body fat present. In addition, total body water progressively decreases with age. In contrast, infants have proportionately more body fluid than any other age group, and so infants are at a higher risk for fluid volume deficit. Body water is distributed both inside of the cells and outside of the cells. The water that is found within the cells is referred to as intracellular fluid, or ICF, and the water found outside the cells is referred to as extracellular fluid, or ECF. Most of the extracellular fluid is found in two compartments, the interstitial space and the intravascular space. The interstitial space is the space between body cells that bathe those cells, and this water fluid is sometimes referred to as tissue fluid or interstitial fluid. Interstitial fluid also includes lymph and cerebrospinal fluids. The intravascular space refers to the blood vessels, and the fluid there is known as plasma or intravascular fluid. An exchange of fluid occurs continuously among the plasma, interstitial fluid, and extracellular fluid. You can see these three compartments depicted on the illustration on this slide. Because the internal environment needs to remain in homeostasis, the intake and the output of fluids must be relatively equal. Normal sources of water include liquids, foods that contain water, and metabolic activity. Usually, the overall intake averages 1,000 to 3,000 milliliters. On the other hand, water is eliminated from the skin, kidneys, bowels, and lungs. Some of this water loss is measurable or sensible, and some is not measurable or insensible. Fluids within the body have several important functions, as you see listed on this slide. The extracellular fluid is responsible for transportation of nutrients to the cells and removing their waste products. Functions of body water fluid include maintaining blood volume, regulating body temperature, transporting material to and from cells, serving as an aqueous medium for cellular metabolism, assisting in digestion of food through hydrolysis, acting as a solvent in which solutes are available for cell function, and serving as a medium for the excretion of waste. As mentioned earlier, body fluids are in constant motion. The movement of particles such as water, electrolytes, and other substances occur through various transport mechanisms which provide for movement between the ICF and ECF compartments. The four primary mechanisms are diffusion, osmosis, filtration, and active transport. Diffusion, osmosis, and filtration are considered passive transport. Passive transport is movement of particles without the need for using the energy of ATP. Diffusion is the passive movement of molecules such as water and ions from a region of concentration to a region of lower concentration across a semi-permeable membrane. In diffusion, the molecules move through pores in the membranes or even by dissolving in the lipids of the cell walls in order to pass through. As long as there is no opposition to diffusion, the molecules will distribute themselves evenly. Osmosis, on the other hand, is the passage of water only from an area of lower particle concentration toward an area of higher particle concentration through a semi-permeable membrane. The semi-permeable membrane, such as a cell wall, is typically more permeable to water than it is to solutes. Filtration refers to the transfer of water and dissolved substances from a region of high pressure to a region of low pressure. For example, the pumping action of the heart provides the pressure that allows the movement of materials from the capillaries to the interstitial fluid. Active transport occurs when molecules need to move in the opposite manner as with passive transport. In this case, movement occurs from lower concentration into higher concentration. This movement necessitates the use of energy, or ATP. The picture on this slide contrasts active transport with passive transport. On the left, you will note that with passive transport, molecules are moving from a region where they have a higher concentration to where the concentration is lower. On the right, you see depicted active transport with ATP, or energy, being used to move additional molecules into an area where the concentration is already higher. The term osmolarity refers to the concentration of solute in a volume of solution. The normal osmolarity of body fluids is between 280 and 295 milliosmoles per liter, and the osmolarity of the ICF and ECF is always equal. The term tonicity is used with reference to the effects of solutions on body cells. A solution with the same osmolarity as body fluids is referred to as isotonic. A solution with less solute concentration than the body's fluid is called hypotonic, and a solution with a higher solute concentration is referred to as hypertonic. In the pictures on this slide, the blue area refers to the solution, and the brown area is depicting the cell. As you can see in the first picture, the hypotonic solution has less solute or molecules dissolved in it than does the cell. In the second picture, the concentration of molecules dissolved in the solution is equal to that of the cell. In the third picture, there are many molecules dissolved in the solution than what we see in the cell. So this is a hypertonic solution. On the next few slides, we will be looking at each of these types of solutions in more detail. As mentioned, isotonic solutions have the same osmolarity as normal body fluids. Examples of these solutions include 0.9% sodium chloride, or normal saline, and 5% dextrose in water, or D5W. Because these fluids have the same concentration of particles as body fluids do, they cause no overfluid shifts. The solution, when administered via IV, remains in the ECF. Water molecules diffuse through the plasma membrane in both directions, and as the rate of water diffusion is the same in each direction, that cell will neither gain nor lose water. Hypotonic solutions contain less solute or particles than the intracellular space, so in a sense they contain extra water. In an attempt to balance the concentration of solutes inside and outside the cell, water will rush into the cell and can cause it to burst. The water is transported into the cells to even out the fluid balance. These solutions are used to hydrate the cells but can deplete the intravascular compartment and cause cells to swell and burst if used too long. Examples of hypotonic solutions include 0.45% sodium chloride, 0.2% sodium chloride, and 2.5% dextrose in water. Hypertonic solutions have a high osmolarity, over 375 milliosmoles per liter. A hypertonic solution is one with a higher concentration of solutes outside the cell than inside the cell. When a cell is immersed into a hypertonic solution, the tendency is for water to flow out of the cell in order to balance the concentration of the solutes. The cells can thus shrink and possibly even shrivel. These solutions include D5W normal saline, 2% sodium chloride, and D10W. Regulation of body water is an important part of homeostasis. Homeostasis means the body is in balance, and homeostasis is constantly challenged by changes to both our external and internal environment. Thus, the human body has several mechanisms to maintain homeostasis. When homeostasis is compromised and imbalance occurs, IV therapy may be prescribed. It is important for the nurse administering IV therapy to understand the underlying mechanisms attempting to regain homeostasis before, during, and after the therapy is being given. Balancing fluids and electrolytes in the body happens by means of various body systems, and we will next briefly review the role of each of those systems in maintaining fluid balance. We are first going to talk about the structure and function of the renal cardiovascular system. The renal system is vital to maintaining fluid and electrolyte balance. The kidney's functions include regulation of fluid volume and osmolarity, regulation of electrolyte levels, regulation of pH and acid-base balance, and excretion of waste products. Ultimately, the kidneys regulate all of the tissue fluid as well. This illustration will help refresh your memory with respect to the three basic processes used by the kidneys in its regulation of fluid and electrolyte balance. These processes include glomerular filtration, tubular reabsorption, and tubular secretion. If the kidneys are not functioning correctly, issues with fluid and electrolyte balance will occur. The pumping action of the heart provides circulation of blood through the kidneys under pressure, which allows urine to form. Without adequate blood flow, the kidneys cannot function correctly. The heart provides the force necessary to circulate blood to all of the tissue in the body, keeps blood moving through the vessels, and supplies tissue with oxygen and nutrients, and removes waste products. Maintenance of adequate fluid balance depends largely on the pumping action of the heart, as does the circulation of IV fluids administered. It will be helpful to briefly review the path of blood flow from the heart. Blood is delivered to the heart by the means of two large veins, the superior vena cava and the inferior vena cava. This blood enters the right atrium and then passes through the tricuspid valve into the right ventricle. Blood leaves the right ventricle, passing through the pulmonary valve and then entering the pulmonary arteries. The right and left pulmonary arteries deliver blood to the lungs, where the blood loses CO2 and gains oxygen. Blood then returns from the lungs via the right and left pulmonary veins and enters the left atrium. Blood next passes to the left ventricle through the mitral valve, and the pumping action of the left ventricle pushes the blood through the aortic valve and into the aorta. Large vessels branching off of the aorta send the blood to the heart, brain, and to the entire body. Baroreceptors located in the carotid sinus and aortic arch respond to the degree of stretch of the vessel wall. The brain, through the autonomic nervous system, can then stimulate fluid retention if these receptors detect hypovolemia. This is done through sympathetic response, causing vasoconstriction of the smooth muscle of the vessel walls. As we progress into the basic concepts of administering IV therapy, it will be helpful to be familiar with the locations of the large veins used to deliver IV therapy in central lines. Note on the illustrations the locations of the jugular veins, the subclavian veins, the superior vena cava, the basilica vein, and the femoral vein. On the hands, there are the digital and metacarpal veins. In the forearm, there are cephalic and accessory cephalic veins, the basilic vein, the median antebrachial vein, the median basilic vein, and the median cubital vein. Note the antecubital space inside the bend of the arm. This slide shows further detail of the different venous sites. Blood vessels are the containers for blood, and blood's primary component is a fluid known as plasma. Arteries are those vessels that carry blood away from the heart. They are thick-walled and muscular, function under high pressure, and regulate blood pressure by changes in peripheral vascular resistance. Veins are the vessels that carry blood back to the heart. These vessels operate under low pressure and have valves to prevent backflow. Systemic veins empty into the superior vena cava or the inferior vena cava. As with arteries, many of the names of veins reflect their location. For example, the subclavian vein runs underneath the collarbone or clavicle, thus its name is subclavian. Arteries branch into smaller vessels, eventually becoming arterioles. The arterioles then branch into capillaries. Once passing through the capillaries, the blood enters small veins called venules, which join together into large vessels, eventually forming veins. Capillaries are the tiniest of blood vessels. The walls of capillaries are very thin and permit osmosis and diffusion to occur. The vast majority of gas exchange occurs at the capillary level. Now let's talk about the role of the skin. Skin is the first barrier to successful venipuncture and the most painful layer during venipuncture due to blood vessels and nerves. Under the epidermis and dermis lies the hypodermis or superficial fascia. This provides a covering for blood vessels. Any infection in the fascia spreads easily throughout the body. Age and physical condition affect the thickness of both the skin and the fascia. The epidermis is the first line of defense against infections. It's the most outer layer of skin. The dermis consists of the blood vessels, hair follicles, sweat glands, small muscles, and the nerves. There are also sensory receptors. The mechanoreceptors process tactile sensations. Thermoreceptors process cold, warmth, and pain. Nociceptors process pain, and chemoreceptors process osmotic changes in the blood. Next, let's review the lymphatic system. The lymphatic system contributes to fluid balance by removing excess interstitial fluid and returning it to the circulatory system. If the lymphatic system does not function correctly, fluid would build up in the interstitial compartment. Next, we will discuss the structure and function of the respiratory system. The respiratory system is a key component for maintaining homeostasis, and it also plays a major role in regulating acid-base balance. The functions of the lungs and body fluid balance include regulation of metabolic alkalosis and acidosis, and removal of approximately 300 to 500 milliliters of water daily through exhalation. Blood pH and levels of oxygen and carbon dioxide have effects on breathing. Decreased blood oxygen is detected by the carotid and aortic chemoreceptors. Increased blood carbon dioxide, which leads to a decreased pH, is detected by chemoreceptors in the medulla. To correct either imbalance, the response is the same: increased rate and or depth of respiration. We also have to discuss the nervous system, which is the master controller in fluid and electrolyte balance through the regulation of sodium and water. It does this work by stimulating various endocrine glands. These pictures show the proximity of nerves to veins. Thus, it's very important to understand how we prevent nerve damage in IV therapy. Now we will talk about the structure and function of the endocrine system. The pituitary hormone that affects water balance is ADH, or antidiuretic hormone. This hormone, which affects renal reabsorption of water, is also referred to as the water-conserving hormone. Osmoreceptors and baroreceptors detect pressure changes, thus stimulating the ADH. You will see increased reabsorption of water and blood vessel vasoconstriction. The intention is to increase blood volume and increase blood pressure. This slide shows how blood osmolality changes stimulate responses to secrete or suppress ADH. The parathyroid gland is embedded in the back corners of the thyroid gland, and it helps regulate calcium and phosphate balance. An increase in parathyroid hormone will increase serum calcium levels but lower serum phosphate levels. Another hormone that regulates calcium is calcitonin, which is secreted by the thyroid gland. Calcitonin works opposite of the parathyroid hormone. It will reduce serum calcium levels. The adrenal glands, located on top of the kidneys, are responsible for aldosterone, epinephrine, norepinephrine, and cortisol. Aldosterone is a hormone from the adrenal cortex that influences fluid balance. Aldosterone is responsible for the renal reabsorption of sodium. By causing the kidneys to reabsorb sodium, chloride and water are also retained, and potassium is excreted. Epinephrine increases blood pressure, enhances pulmonary ventilation, dilates blood vessels needed for emergencies, and constricts unnecessary vessels. Norepinephrine stimulates vasoconstriction throughout the body, which raises blood pressure. Cortisol is a hormone secreted by the adrenal cortex also. When produced in large quantities, it can produce sodium and fluid retention and potassium deficit. This slide shows how a decrease in sodium or increase in potassium stimulates the adrenal gland to produce aldosterone. Let's review the hormones. ADH, antidiuretic hormone, directly decreases urinary output. PTH, parathyroid hormone, helps regulate blood calcium and phosphate levels. Aldosterone indirectly decreases urinary output by increasing the reabsorption of sodium ions followed by water. Atrial natriuretic hormone, ANH, or also known as atrial natriuretic peptide, ANP, increases urinary output by increasing the excretion of sodium ions followed by water, acting like a diuretic. This slide shows the renin-angiotensin-aldosterone system and how it increases blood volume and pressure. Prior to initiating IV therapy, the registered nurse is required to do the initial assessment. The LPN may contribute to data collection and should do so throughout the IV therapy. Nurses should always monitor vital signs and intake and output for patients receiving IV therapy, and at least once per shift assess body systems in order to monitor the patient's reaction to the IV therapy. We will next do a brief review of the physical assessment portion of this data collection. Physical assessment not only establishes a baseline, but helps the nurse and physician to evaluate the effectiveness of the prescribed therapy. Data collection is essential in order for the nurse to be able to intervene when appropriate and to identify complications and side effects to the prescribed therapy. The nurse collects relevant data about the patient's past medical history and attempts to validate subjective information gathered. Let's start with the central nervous system. Fluid volume changes affect the CNS cells and can result in confusion, stupor, seizures, and eventually coma. Additionally, the aging process or an illness can cause a decrease in the sensation of thirst. Level of consciousness can be affected by changes in serum osmolality, fluid volume, and electrolytes. CNS cells are also significantly affected by alterations in serum sodium levels, which can accompany fluid volume changes. The nurse will collect data about the patient's neurological status, including level of consciousness, and note any evidence of neuromuscular irritability, such as muscle spasms or twitching. The importance of assessing for neuromuscular irritability increases when electrolyte imbalances are suspected. Moving on to cardiovascular. The nurse should monitor not only the pulse rate, but the quality of the pulse, such as bounding or threading. The quality and rate of the pulse are indicators of how the patient is tolerating the IV fluids. The nurse can look at the peripheral veins, such as in the hands, and see if these veins empty slowly or rapidly upon elevation of the hand. In addition, the nurse should assess for JVD or jugular venous distension. Changes in fluid volume are reflected by changes in the neck vein filling. The nurse will also routinely monitor blood pressure for the patient receiving IV therapy and monitor for orthostatic hypotension and also for significant increases in blood pressure from the baseline. Finally, the nurse assesses for edema. Edema should be assessed not only in the ankles and legs, but also over bony surfaces in the face and in the extremities. If edema is noted, the nurse should determine if there is pitting and rate it accordingly. The nurse would also compare sides of the body for symmetry of the edema. Edema in the extremity where a peripheral IV is located requires immediate intervention. Data collection of the respiratory system for the patient receiving IV therapy includes listening to lung sounds, monitoring respiratory rate and depth. Any variances need to be reported. Crackles can indicate fluid overload, and alteration in depth and rate can be an indicator of an acid-base imbalance. Assessments of temperature and skin surface are vital in determining fluid volume changes. Skin turgor can be assessed by pinching the area of the hand or sternum. Assessing skin turgor over the sternum is more accurate for elderly patients than the hand is. In a person with normal fluid volume, the pinched skin normally falls back to its normal position when released. This would be referred to as elastic turgor. However, if there is fluid volume deficit, the skin may remain elevated for several seconds. This would be referred to as tenting. The nurse will also monitor for fingerprint edema, which is a condition in which placement of the nurse's fingers on the patient's skin for 15 to 30 seconds leaves finger imprints. Additionally, the nurse will assess capillary refill to verify circulation and skin temperature. Any variations in capillary refill or skin temperature in the extremity where the IV is located requires intervention immediately. The eyes, mouth, lips, and tongue are also key indicators of fluid volume imbalances. The absence of tearing and salivation in a child is a sign of fluid volume deficit. In adults, furrowing and dry, sticky mucous membranes can be signs of fluid volume deficit. The lips may be dry and cracked. Accurate body weight measurement is a better indicator of fluid gains or losses than intake and output records. A loss or gain of 1 kilogram or 2.2 pounds reflects a loss or gain of 1 liter of fluids. Fluid volume imbalances may reflect an increase or a decrease in total body fluid or an altered distribution of body fluids. There are two major alterations in fluid balance. There's fluid volume deficit and fluid volume excess. Fluid volume deficit or hypovolemia reflects a contracted vascular compartment from significant ECF loss or accumulation of fluid in the interstitial space. ECF deficit is also called dehydration and may be caused by a variety of factors, including an actual decrease in body water, excessive fluid loss, inadequate fluid intake, or third spacing. Excessive fluid losses can be due to conditions such as vomiting, diarrhea, hemorrhage, wound drainage, burns, diuretic therapy, and others. Clinical manifestations of fluid volume deficit can include weight loss, altered cardiac functioning, such as tachycardia and low blood pressure, poor skin turgor, oliguria, no tearing or saliva in kids, LOC changes, and others listed on this slide. As mentioned earlier, these manifestations may be caused by a fluid loss, for which IV therapy may be prescribed to treat. These manifestations can also happen when fluid accumulates in the interstitial space, which can occur even if IV fluids are being given. Laboratory findings in fluid volume deficit reflect hemoconcentration with the serum hemoglobin, hematocrit, and proteins increased, along with urine-specific gravity reflecting a high concentration. Treatment for fluid volume deficit includes fluid replacement, orally or via IV, until fluid balance stabilizes. Isotonic solutions are used to treat hypotensive patients with a fluid volume deficit. Extreme caution must be used in fluid replacement to avoid fluid overload. The physician will also focus on treating the underlying cause for the dehydration. The nurse will monitor vital signs, provide oral fluids at least hourly, and monitor for complications or improvement by the data collection demonstrated on this slide. Eyes and nose, laboratory values, cardiovascular respiratory assessments, assess for orientation, vision, hearing, reflexes, and muscle strength, daily weights, oral and skin care, and watch closely for developing complications. Fluid volume excess, or hypervolemia, is frequently caused by cardiovascular dysfunction such as CHF, congestive heart failure. Other disorders can cause this condition, and it is often related to an increase in sodium. Other conditions causing overhydration include excessive administration of oral or IV fluids, use of hypotonic fluids, and syndrome of inappropriate antidiuretic hormone secretion, SIADH. The most prominent symptom of fluid volume excess is weight gain. Other symptoms can include hypertension, tachycardia, crackles in the lung fields, edema, distended veins, and sometimes changes in level of consciousness. Edema is usually not apparent until 2 to 4 kilograms of fluid have been retained. In fluid volume excess, the hematocrit may be decreased because of hemodilution. The serum sodium and serum osmolarity will be decreased if hypervolemia occurs as a result of excessive water retention. Treatment of fluid volume excess is directed towards sodium and fluid restriction, administration of diuretics, and treatment of the underlying cause. Nursing interventions include monitoring vital signs, weight, edema, diet, lung sounds, and urine output. The next section discusses the fundamentals of electrolyte balance. Most of the electrolytes in the body have more than one role. Roles of electrolytes in the body include maintaining electroneutrality of fluid compartments, mediating enzyme reactions, altering cell membrane permeability, regulating muscle contraction and relaxation, regulating nerve impulse conduction, and influencing blood clotting time. The electrolyte content of the intracellular fluid differs from that of the extracellular fluid. Usually, only plasma electrolytes are measured and are important in the assessment and management of patients with electrolyte imbalances. The main function of sodium is to maintain ECF volume. Sodium represents about 90% of all extracellular cations and does not easily cross cell wall membranes. Sodium works along with potassium and calcium to conduct nerve and muscle impulses and regulate acid-base balance. The kidneys are vital to the regulation of sodium, and aldosterone plays a key role. Hyponatremia refers to a deficiency of sodium in relation to body water. In other words, body fluids are diluted. A low sodium level can be the result of an excessive loss of sodium or an excessive gain of water. Severe hyponatremia can lead to seizures, coma, and permanent neurological damage. All GI secretions contain sodium. Therefore, any abnormal loss of GI secretions can cause a sodium deficit. GI disorders such as vomiting, diarrhea, drainage from suction or fistulas, and excessive tap water enemas may also cause hyponatremia. Excessive water consumption and thiazide diuretics, adrenal insufficiency, medications, and other hormone imbalances are just a few of the many other causes of hyponatremia. Signs and symptoms of hyponatremia may vary from patient to patient and can also vary depending on how quickly the sodium level dropped. Hyponatremia affects cells of the CNS. Symptoms can include anorexia, muscle cramps, feeling exhausted, confusion, and if water gain related, fingerprint edema. In addition to the serum sodium level, the physician will typically also order a serum osmolarity, urine-specific gravity, and urine sodium, and a hematocrit level. Treatment varies depending on the cause and severity of the hyponatremia. Treatment aims at replacing sodium either orally or intravenously. IV fluids used to treat hyponatremia can include lactated ringers or normal saline. If the hyponatremia is very low, a hypertonic saline solution may be used. Oral water restriction may also be ordered. Nurses will closely monitor lab tests, I's and O's, and daily weights. Increased sodium levels can be caused by a gain of sodium without gaining extra water, or by losing water without losing sodium. Hypernatremia occurs much less frequently than hyponatremia. Severe hypernatremia also can lead to seizures, coma, and severe neurological damage. Most commonly, hypernatremia can be caused by water loss from fever or respiratory infection. It can also occur with water deprivation or even when a person is drowning in seawater. Sodium is also lost with certain medications, water diarrhea, heat stroke, and in other circumstances. The most important signs of hypernatremia will be neurologic because of the effects of fluid shifts on brain cells. Signs and symptoms of hypernatremia can include thirst, elevated body temperature, swollen tongue, dry and sticky mucous membranes, disorientation, and neuromuscular irritability. To help you remember some common signs and symptoms of hypernatremia, think of the word salt. Skin flushed, agitation, low-grade fever, and thirst. Diagnostic tests that a physician may order in addition to the serum sodium level might include serum osmolarity and urine-specific gravity. Treatment of hypernatremia varies with the cause, as the underlying disorder will need to be corrected also. The physician will treat hypernatremia by gradually lowering the serum sodium level in order to decrease the risk of cerebral edema. The physician may order either isotonic or hypotonic solutions and may also include diuretics that deplete sodium. Now let's talk about potassium. Potassium plays a crucial role in many cell functions. 98% of the potassium in our bodies is found in the ICF. Many diseases, injuries, and medications can disturb potassium levels. Small, untreated alterations in potassium levels can seriously affect neuromuscular and cardiac functioning. Potassium must be ingested daily because the body does not conserve it. Sodium and potassium have a reciprocal relationship. The kidneys reabsorb sodium and excrete potassium under the influence of aldosterone. The kidneys really cannot combat loss of potassium and may excrete it even when the serum potassium level is low. Many conditions can lead to potassium deficit, including GI and renal losses, potassium wasting diuretic use, sweat loss, poor diet, shifting into cells with excessive insulin, and many other causes. Even a slight decrease in potassium has profound consequences. Intestinal fluids contain large amounts of potassium, so severe GI losses can deplete the body's supply. Signs and symptoms are typically neuromuscular related, such as fatigue, muscle weakness, leg cramps, diminished deep tendon reflexes, GI symptoms, and EKG changes. Paralysis could occur even with respiratory muscles. To help you remember some of the signs and symptoms of hypokalemia, think of the word suction. Not only can suction cause hypokalemia, but the letters will help you remember signs. Skeletal muscle weakness, U-wave change on EKG, constipation, toxicity of digitalis, irregular weak pulse, orthostatic hypotension, and numbness. Labs that the physician might order in addition to serum potassium might include ABGs and magnesium. Cardiac arrest can result from hypokalemia. Treatment revolves around replacing the potassium either orally or via IV. Potassium should never be given IV push. Concentrated potassium solutions must always be diluted. Never add potassium to a hanging container. IV potassium must be administered slowly, and if it infiltrates, it can cause serious tissue loss. Rates are usually 10 milliequivalents per hour. Nursing management also includes monitoring cardiac and respiratory function, monitoring vitals, and assessing for digitoxicity. Hyperkalemia occurs when the potassium levels rise above 5 milliequivalents per liter. Again, a slight increase can have profound consequences. Even though hyperkalemia is less common than hypokalemia, it can be more serious. Hyperkalemia can be caused by increased potassium intake, decreased potassium excretion such as in kidney failure, acid-base imbalances, and cell injuries such as crush injuries or burns. Hyperkalemia can also be caused by too much intake, such as with excessive use of salt substitutes. Blood transfusions and certain medications can also lead to hyperkalemia, such as beta blockers, potassium-sparing diuretics, ACE inhibitors, and chemotherapy. Potassium can leave cells when the cells have been injured by burns, trauma, crush injuries, and chemotherapy. So all of these situations put the patient at risk for hyperkalemia. Signs and symptoms of hyperkalemia reflect its role in neuromuscular and cardiac functioning. Early signs of hyperkalemia can be paresthesias and irritability. Signs can include muscle cramps or muscle weakness, decreased heart rate, irregular pulse, hypotension, EKG changes, decreased cardiac output, and possibly cardiac arrest. Beyond a serum potassium level, the physician may also order an ABG and EKG. Pseudohyperkalemia can occur if the extremity used for the venipuncture was recently exercised, or if the tourniquet was too tight and the cells lysed when the specimen was obtained. Mild hyperkalemia may be treated with loop diuretics to increase potassium loss. Kexalate may be ordered, which causes the sodium to move from the bowel to the blood, and potassium then moves from the blood to the bowel in its place, causing diarrhea and excretion of the potassium. Emergency treatment may include IV calcium gluconate, IV sodium bicarbonate, and D10W, which causes the potassium to shift into cells. Dialysis may be needed. Nursing management is similar to that for hypokalemia. 99% of the body's calcium is found in the bones and teeth, and the other 1% is in the serum and tissue. Calcium is important for several body functions, including the formation of bones and teeth, maintaining cell function, nerve and muscle impulse transmission, and blood clotting. Several factors impact calcium levels in the body, such as PTH, calcitonin, phosphorus, and vitamin D, which is needed for its absorption. Hypocalcemia can occur because of poor intake of calcium, poor absorption of calcium, or excessive loss of calcium. Alteration in the regulation of calcium by hormone issues with calcitonin or PTH can play a role. Typically, hypocalcemia occurs with nutritional deficiency of calcium or vitamin D, or in bone disorders such as metastatic cancer of the bone. There are many other possible causes of hypocalcemia. Signs and symptoms often reflect the effect of calcium on nerve and muscle function, including the heart. The patient may experience numbness, muscle cramps, hyperactive reflexes, laryngospasm, tetany contractions, delusions, seizures, and arrhythmias. Testing for Trousseau's and Chauvet-Stech signs can aid in the diagnosis of tetany and hypocalcemia. To test for Trousseau's sign, apply a blood pressure cuff to the patient's upper arm and inflate it to a pressure of 20 millimeters of mercury above the systolic pressure. Trousseau's signs may appear after 1 to 4 minutes. The patient will experience muscle spasm of the hand and wrist with an adducted thumb, flexed wrist, and fingers together for a positive sign. Chauvet-Stech sign is checked by tapping the patient's facial nerve adjacent to the ear. A brief contraction of the upper lip, nose, or side of the face indicates a positive Chauvet-Stech sign. The most dangerous symptom associated with hypocalcemia is the possibility of laryngospasm and tetany-like contractions. Treatment focuses on the underlying cause, and the physician may also order oral or IV calcium gluconate. Nursing management includes monitoring cardiac and respiratory function and seizure precautions. If the patient has a low magnesium, the magnesium must be corrected before IV calcium will increase the serum calcium levels. Also, check the phosphate level. If it is too high, the calcium will not be absorbed. IV calcium must be diluted in D5W and administered slowly. There are 2 major causes of hypercalcemia: hyperparathyroidism and cancer. In hyperparathyroidism, the body excretes more PTH than normal. Cancer can cause bone destruction if malignant cells invade the bones. Other cancers, such as lung cancer, myeloma, and breast cancer, can also contribute to hypercalcemia. Symptoms tend to be more severe if this condition develops rapidly. Again, neuromuscular symptoms and GI symptoms may be seen. Treatment again starts with treating the underlying disease. Increased fluids, possibly dialysis, calcitonin, and Lasix. Nursing interventions are similar to those discussed previously and also include handling the patient gently to prevent bone fractures. Magnesium's functions include promoting enzyme action, energy, protein synthesis, vasodilation, regulation of neuromuscular activity, and regulating electrobalance such as sodium and potassium. Hypomagnesemia can result from chronic alcoholism, malabsorption, suctioning, diarrhea, and others. Signs and symptoms of hypomagnesemia can cause CNS irritation and the 3 T's and hyper-DTRs. Tremors, twitching, tetany, and hyperactive deep tendon reflexes. EKG changes may occur along with respiratory difficulties. Hypomagnesemia is very hard on the heart. It can cause a fatal arrhythmia. Treatment includes magnesium replacement. Nursing management includes monitoring cardiac and respiratory function and seizure precautions. IV magnesium is administered slowly and with continuous cardiac monitoring and frequent vital sign monitoring. Having too much magnesium can be as bad as having too little. Hypermagnesemia results from conditions opposite of those of hypomagnesemia. Renal dysfunction and excessive intake of magnesium are the primary causes. Drugs such as antacids, laxatives, and magnesium supplements provide an extra source of magnesium. Excess magnesium depresses the CNS, so the patient may appear drowsy and lethargic, and the LOC may change to the point of coma. Muscle weakness can be profound and affect respiratory and cardiac function, leading to respiratory or cardiac arrest. It can also cause vasodilation, which can lower blood pressure and cause flushing. A memory aid is the word renal. Reflexes decreased, EKG changes, nausea, appearance flush, and lethargy. Another way to check for hypermagnesemia is to check the patellar reflex. If it is absent, it can mean the patient has hypermagnesemia. Treatment can include increased fluids to flush the magnesium out, loop diuretics, or calcium gluconate. Phosphorus, or phosphate, is important to cells for energy, metabolism, cell membranes, DNA, oxygen delivery, and as an acid-base buffer. Phosphorus and calcium have a reciprocal relationship, so if one is elevated, the other is decreased. The parathyroid gland controls the hormonal regulation of phosphate via the parathyroid hormone. Hypophosphatemia can result from malabsorption syndromes, alcohol withdrawal, medications, hormonal disturbances, and others. Diuretic use is the most common cause of phosphorus loss through the kidneys. Signs and symptoms of a low phosphate level appear in the nervous system, neuromuscular system, and cardiac system. Muscle weakness is a key symptom, which can progress to respiratory muscle weakness and respiratory failure. To help you remember some of the signs and symptoms of hypophosphatemia, think of the word imbibing, as alcoholism is a principal cause of hypophosphatemia. Imbibing stands for irritability, malaise, bleeding, inflammation, bone or muscle pain, infection risk, numbness, and generalized weakness. Treatment may include oral or IV phosphate replacement. Hyperphosphatemia is usually caused by renal disease, cancer, and hypoparathyroidism. The kidneys may be unable to excrete extra phosphate, and this may occur in combination with an increased release of phosphorus from damaged cells. Symptoms may include CNS changes and symptoms related to low calcium level. Because of the inverse relationship it has with calcium, a high phosphate level can lead to life-threatening hypocalcemia. To help you remember some of the signs and symptoms, think of the word chemo, since chemotherapy can lead to hyperphosphatemia. It stands for cardiac irregularities, hyperreflexia, eating poorly, muscle weakness, and oliguria. Treatment focuses on identifying the underlying cause, and a phosphate-binding medication may be administered to eliminate excessive phosphate. Functions of chloride relate to regulation of fluid balance, regulation of acid-base balance, control of acidity in gastric juice, and others. Chloride combines with the major cations, such as sodium and potassium, to form substances such as sodium chloride. hydrochloric acid, potassium chloride, and others. Typically, an alteration in chloride level is related to another electrolyte disturbance. Chloride has a reciprocal relationship with bicarbonate, so a lower bicarbonate level results in a rise in chloride level and vice versa. Chloride is also closely linked to sodium, so a change in sodium can also result in a change in chloride. Hypochloremia happens mainly as a result of GI losses, whereas hyperchloremia can occur with head trauma, hormonal issues, and dehydration. Signs of hypochloremia include neuromuscular symptoms and depressed respirations along with alkalosis. On the other hand, signs of hyperchloremia could include symptoms of acidosis, and signs of hyperchloremia rarely occur on their own but as a result of the acidosis. In both disorders, the nurse might anticipate labs to include chloride level, pH, and also EKGs. Treatment focuses on first treating the underlying cause. Acid-base balance is really a reflection of the concentration of hydrogen ions. A solution is either basic or acidic on the basis of the concentration of hydrogen ions in the solution. On the pH scale, 7 is neutral, below 7 is acidic, and above 7 is basic or alkaline. The pH number assigned has an inverse proportion to the concentration of hydrogen ions. So a lower pH indicates a high hydrogen concentration, and a higher pH indicates a lower hydrogen concentration. The normal pH of arterial blood ranges from 7.35 to 7.45. A variation of 0.4, either above or below this range, can be fatal. So the body is constantly working to maintain the blood pH within its normal range. When the blood pH is below 7.35, we refer to it as being acidosis, since it is heading toward the acid side of the pH scale. When the blood pH is above 7.45, it is referred to as alkalosis, since the blood is more alkaline. Because maintaining control of blood pH is critical for life, the body is constantly working to maintain this delicate balance. There are 3 primary mechanisms that function to maintain pH balance. These mechanisms are the chemical buffer systems, the respiratory system, and the renal system. We will next briefly describe the role of each of these mechanisms in controlling blood pH. The chemical buffer systems act fast and first. These systems provide immediate protection by reacting to minimize pH changes. There are 3 primary buffer systems: the bicarbonate buffer system, the protein buffer system, and the phosphate buffer system. Protein buffer systems include hemoglobin, amino acids, and plasma proteins. These systems are the first to respond to keep pH in balance and consist of pairs of chemicals. The chemicals bind to either strong acids or strong bases, thus weakening the acid or base. The respiratory system is very efficient and can compensate for metabolic disturbances quickly, whereas the kidneys can take days to compensate for an imbalance. A decrease in blood CO2 increases the blood's pH, causing it to become more alkaline. So an increase in respiratory rate causes CO2 to be blown off by the lungs, resulting in an increase in blood pH. On the other hand, a decrease in respiratory rate causes retention of carbon dioxide and thus a decrease in pH. This means that the lungs can either raise or lower the blood pH by altering the respirations. The kidneys regulate hydrogen ion concentration by excreting hydrogen or retaining hydrogen. Although the kidneys are the most powerful regulating mechanism, they are slow to make major changes in the acid-base balance. The body constantly works to maintain the balance between acids and bases. Without the balance, proper cell functioning cannot take place. Ultimately, the amount of free hydrogen ion determines acid-base balance. There are 2 types of acid-base imbalances: acidosis and alkalosis, and 2 major causes: metabolic and respiratory. Most of the time, the compensatory mechanisms we just discussed restore pH imbalances. Sometimes, however, the imbalance is too significant for the body's compensatory mechanisms, and the patient needs medical intervention. Arterial blood gases are the best diagnostic tool for determining acid-base imbalances. An ABG includes the arterial pH level, the PaCO2 level, and the bicarb level, which is HCO3. The arterial pH should be 7.35 to 7.45. The carbon dioxide pressure should be 35 to 45 millimeters of mercury, and the bicarb, HCO3, should be 22 to 26 milliequivalents per liter. IV therapy may be used to help alleviate an acid-base imbalance. Remember, though, that IV fluid has its own pH value and it may inadvertently contribute toward a pH imbalance. For those reasons, it is important to be familiar with acid-base imbalances. We will next briefly review the major acid-base imbalances: metabolic acidosis and metabolic alkalosis, and respiratory acidosis and respiratory alkalosis. Causes of metabolic acidosis include severe diarrhea, renal failure, shock, draining fistulas, and even TPN administration. Hyperkalemia is also usually present. Signs and symptoms are often CNS related, such as headache, LOC changes, and drowsiness. Other symptoms include respiratory changes and nausea and vomiting. ABG results will indicate a pH under 7.35 and bicarb less than 22. Treatment includes treating the underlying cause and perhaps IV sodium bicarb. Causes of metabolic alkalosis include vomiting, gastric suctioning, diuretic therapy, excessive antacid consumption, and potassium deficit. Metabolic alkalosis is characterized by an elevated pH and an elevated bicarb. Signs and symptoms of metabolic alkalosis can include dizziness, depressed respirations, LOC changes, tremors, muscle cramps, tingling of fingers and toes, and others. Treatment again includes treating the underlying cause, administration of chloride, and correcting any potassium deficit that may exist. Respiratory acidosis is caused by inadequate excretion of carbon dioxide and inadequate ventilation. This in turn raises the serum carbon dioxide level and the bicarb. This situation can be caused acutely by respiration depression, airway obstruction, aspiration, pulmonary embolus, cardiac arrest, and others. Chronic respiratory acidosis results from COPD and similar conditions that restrict the airway. Signs and symptoms can include tachypnea, dyspnea, dizziness, muscle weakness, and eventually dysrhythmias such as ventricular fibrillation. The patient may complain of a headache since increased carbon dioxide dilates cerebral blood vessels. Even though most patients have a rapid respiratory rate, if the acidosis is caused by CNS trauma or drug overdose, the respiratory rate may be decreased instead. In respiratory acidosis, the pH is low and the PaCO2 is high. The bicarb may be normal if the acidosis is more chronic, but may be elevated in acute respiratory acidosis. Treatment focuses around improving ventilation. Instead of the underventilation that causes respiratory acidosis, respiratory alkalosis is caused by overventilation or hyperventilation. Hyperventilation blows off too much carbon dioxide, which results in a decrease in blood pH. Signs of respiratory alkalosis can include lightheadedness, lethargy, numbness, and tingling of extremities, and others, including seizures and loss of consciousness. The pH will be over 7.45, and the PaCO2 will be low, and the bicarb may also be low. Treatment again involves correcting the underlying cause. The patient may be instructed to breathe into a paper bag. This slide illustrates the differences between respiratory acidosis and respiratory alkalosis. Once obtaining the ABG, or the blood gas result, if you have an elevated hydrogen ion, that leads to acidosis, and also an elevated carbon dioxide, that is respiratory acidosis. If the hydrogen ion is decreased, that is alkalosis, and the pressure of carbon dioxide will be decreased, that is respiratory alkalosis. In summary, when looking at ABGs, you first look at the pH. A normal pH is 7.35 to 7.45. If it is less than 7.35, it is considered acidotic. If it is greater than 7.45, it is considered alkalotic. The pressure of carbon dioxide, the normal range is 35 to 45 millimeters of mercury. And the bicarb, HCO3, the normal range is 22 to 26 milliequivalents per liter. Consider the mnemonic ROAM. Respiratory opposite. That means that pH is increased, the PCO2 is decreased, that leads to alkalosis. If the pH is decreased and the PCO2 is increased, that is acidosis. And then metabolic equal. Okay, so R for respiratory, O for opposite, M for metabolic, E for equal. So for metabolic equal, if the pH is increased and the bicarb is increased, that is alkalosis. And if the pH is decreased and the bicarb is decreased, that is acidosis. Another thing to keep in mind is the HCO3 or bicarbonate is a weak base. There are a wide variety of parenteral solutions available today. These fluids can contain fluids, electrolytes, vitamins, and/or medications. We will first look at the objectives of IV therapy, then briefly overview some of the commonly used IV solutions. To understand the use of parenteral solutions, it is important to ascertain the reason why the physician ordered the solution. This will help the nurse to collect data about the effectiveness of the IV therapy. It is also important to be familiar with the type of solution ordered and its composition, so as to monitor for side effects and complications. First, understand why the physician ordered the IV fluid. Perhaps they wanted the fluids as a maintenance therapy. Maintenance therapy provides nutrients that meet the daily needs of a patient for water and electrolytes. This is typically the patient that is NPO or has an oral fluid restriction. This type of IV therapy is designed to meet the daily needs of the patient. In addition to water, these fluids may contain dextrose, electrolytes, and vitamins. Sometimes the objective of the IV fluids is replacement therapy. In these cases, the IV fluids are required to meet fluid and electrolyte needs of patients in acute distress. Examples can include patients who experience a hemorrhage or that had a period of vomiting and diarrhea. Restoration therapy is IV fluid therapy that is ongoing to restore a continuous loss. Evaluation of current losses is done daily and relies heavily on I&Os. With these types of patients, it is not uncommon to see frequent changes in the orders. The type of restoration fluid depends on the type of fluid that is being lost. For example, if the patient is losing GI fluid due to suctioning, the IV fluid ordered will contain some of the electrolytes that are being lost to the suctioning, such as potassium and chloride. The key elements that make up parenteral fluids include water, carbohydrates or dextrose, protein, vitamins, and electrolytes. The IV fluids also have a pH value, with most of the fluids having a pH around 5. As the acidity of a solution increases, there is more risk of vein irritation. The effect of the IV fluid on the body fluid compartments depends on how its osmolarity compares with the patient's serum osmolarity. IV fluids can change the fluid compartments in one of three ways. First, isotonic fluids can expand the intravascular compartment. These fluids are used to expand volume, so they're also known as volume expanders, to dilute medications, and to keep the vein open at times. They are used for fluid resuscitation and include 0.9 normal saline and lactated ringer solution, or LR. The danger with isotonic solutions is circulatory overload, as they do not cause fluid shifts into other compartments. Hypertonic fluids can expand the intravascular compartment and deplete the intracellular and interstitial compartments. These fluids are used to replace electrolytes and to shift fluids from the ECF into the plasma. Hypertonic fluids are irritating to vein walls and may also cause circulatory overload. Hypertonic fluids can also cause cell crenation or shrinking. Examples of hypertonic fluids include D5W in normal saline, D5LR, D10W, D20W. Hypertonic fluids should be given slowly to prevent circulatory overload. Hypotonic fluids can expand the intracellular compartment while depleting the intravascular. The body fluids will shift out of the blood vessels and go into the cells and interstitial spaces. Hypotonic fluids hydrate cells, but also can deplete the circulatory system. 0.45 normal saline is an example of a hypotonic fluid. Hypotonic fluids should not be given to a patient with low blood pressure since they can cause further hypotension. D5W is isotonic when outside the body, but after it's infused, it becomes hypotonic when the body uses the dextrose. D5W should not be given to infants or to head injury patients due to the risk of cerebral edema. D5W, although isotonic, has dextrose, which metabolizes quickly. That's why it becomes hypotonic. It only provides 170 calories per liter, so it is not a good source of carbs or dextrose. If needed, more dextrose should be given via central line, not discharged abruptly and given slowly. Ringers contain sodium, potassium, calcium. Lactated ringers contains sodium, potassium, calcium, and also lactate, which the liver converts to bicarb. Keep these things in mind when thinking about hypotonic solutions. They are under 250 in terms of osmolarity. They deplete the ECF, the extracellular fluid. They shift fluid out of blood vessels and into the cells and interstitial spaces. They're used to hydrate cells. You do not give it if there is low blood pressure. You monitor for hyponatremia and hypotension. They can cause cardiovascular collapse from vascular fluid depletion. They can also cause increased intracranial pressure from fluid shifting into brain cells. And they can also cause lysis through cell swelling and bursting. Again, examples of hypotonic solutions include 0.45 normal saline, 0.33 normal saline, 2.5 DW, and D5W. Now let's discuss crystalloids and colloids. Crystalloids are small molecules that easily cross membranes depending on tonicity. Examples of these include dextrose and saline solutions. Colloids are large molecules that do not dissolve. They stay in the vascular space for days and they draw in fluid. They are always hypertonic. Examples include dextran, albumin, and hetastarch. We will finish with a review of common IV fluids and discuss their uses, advantages, disadvantages, and side effects. First, let's look at dextrose solutions. Advantages to dextrose solutions are that they can be used as a diluent for IV drugs, as treatment for dehydration, and in larger amounts for nutrition and calories. Dextrose can be used in high concentrations for treatment of hyperkalemia, and dextrose solutions provide free water. However, disadvantages are vein irritation, hyperinsulinism, and it is difficult to administer enough calories by IV infusion, especially with D5W, which gives only about 190 calories per liter. Before any medication is added to a dextrose solution, compatibility should be checked. All dextrose solutions are acidic and can cause thrombophlebitis. Advantages to saline solutions are that they can be a diluent for IV drugs. Treatment for dehydration, replacement of electrolytes, can treat patients with sodium depletion or hyponatremia. Saline solutions are the only solutions that can be used with blood products. Disadvantages is that saline solutions can cause hypernatremia, hypokalemia, and circulatory overload. Dextrose is also available combined with sodium chloride. This combination prevents formation of ketones, and this combination is often used when there has been an excessive loss of fluid through sweating, vomiting, or gastric suctioning. Lactated Ringer's is the most commonly prescribed solution, and it has an electrolyte concentration closely resembling the ECF compartment. It is often used to replace fluid loss from burns, bile, and diarrhea, in addition to all types of dehydration. There are some drug incompatibilities, so it is important to check that. Ringer's solution has some similarities but does not contain lactate. So Ringer's solution can be used when the patient has liver disease and cannot tolerate the lactate in the lactated Ringer's solution. Let's review common IV fluid information. Remember that a solute is a substance dissolved in a solution. Solvent is the solution holding the solute. Central includes access into the vena cava. Peripheral includes access into an arm vein. TPN is total parenteral nutrition, which is nutritional support via central access. And parenteral means that we bypass the GI tract. And now for legal review, determine whether or not the LPN can initiate and maintain the following solutions: D5W, D10W, 0.9% normal saline or NaCl, 0.45% normal saline, 0.33% normal saline, 3% normal saline, D5.9% normal saline, lactated Ringer's, and D5 LR. Now we will discuss the principles and practice of infection control and universal precaution as related to IV therapy. We have to break the chain of infection. Remember the 6 links: reservoir, infectious agent, portal of exit, mode of transmission, portal of entry, and susceptible host. We have to remember hand hygiene, the necessity of sterile technique with IV fluids, the use of medical asepsis to prepare for IV therapy, and cleansing agents, keeping in mind whether or not the patient has allergies, especially iodine. Because there is risk of exposure to blood, risk of exposure to all other body fluids, non-intact skin is present, and the risk of contact with mucous membranes, we have to consider standard precautions, including hand washing, gloves, mask, eye protection, a face shield, and maybe even a gown. Standard precautions apply to blood, all body fluids, excretions and secretions, non-intact skin, and mucous membranes. When we're talking about hand washing, we either use soap and water, chlorhexidine, and do a 15 to 20 second scrub. We hand wash after touching or after removing gloves. Gloves need to be clean, changed between tasks and patients, and you remove gloves promptly after use. Masks, eye protection, and facial protection is used if the patient care activities are likely to generate splashes or spray. We would use a gown to protect our skin and to prevent soiling of clothing. And if patient care activities are likely to generate splashes and spray. Other precautions include transmission-based precautions. There's airborne, which includes respiratory protection like the HEPA or the N95. Diseases include TB or tuberculosis, varicella, and measles. Droplet precautions would include mask and eye protection. Examples include mumps, rubella, influenza, and pertussis. Contact precautions would require gloves, gown, and hand washing. These include C. diff, MRSA, and VRE. Think about patient placement, PPE, transport, and patient care equipment. Summary strategies for infection prevention including following appropriate hand washing procedures, knowing the difference between what is clean, disinfected, and sterile, knowing what is considered dirty, and correcting contamination immediately, as well as following CDC standard precaution guidelines. In IV therapy, it's imperative that we protect the IV site and what goes into it, both before, during, and after IV therapy. This concludes the second module.